It's often one thing that sets off panic disorder and then another thing that continues it. Just having one panic attack or a couple of panic attacks is not panic disorder. There'll be something that starts off the first panic attack. In this situation, it was probably related to grief after her father died. But then once the person has one, they become afraid of the symptoms, especially if she thought she was having a heart attack, right? So then the person tends to become very hyper-vigilant to the physical symptoms of anxiety. And then whenever they notice it, it becomes a feed-forward loop. You start to notice the first couple of symptoms, heart racing, shortness of breath, and then you get afraid, oh no, something bad is really happening, this is happening again. And then that leads to more release of stress hormones and adrenaline and cortisol and all that. And then it leads to a full-fledged panic attack. So panic attacks are one of the few physiological processes that are feed-forward loops rather than feedback loops. Feed-forward is like when it starts, it's more likely to, finish. In terms of treatment for panic disorder, is exposure therapy is part of the treatment for panic disorder, but exposure therapy, it's not necessarily ERP. It's exposing yourself to the symptoms of panic. So this is how I would think about it, because there's kind of two issues. One, she's having the panic disorder, and the other is she hasn't been able to tolerate any medication that could potentially be helpful. So it sounds like she's interested in inositol and saffron. I think that's great. Exactly what you said is what I would do. I'm like, at least let's get something in her system, lower the anxiety threshold a little bit. Inositol has plenty of evidence for panic disorder. And so I would want her to be successful with it, meaning I might have her started even lower than a typical starting dose, which is typically 2 grams 3 times a day. I might honestly even have her take it before our session, meaning that the tendency is going to be she takes something, is extra vigilant to what her body's physical reaction to that is, and then gets anxious and then has one of those feed-forward loops where maybe it turns into a panic attack or even just maybe a more minor anxiety attack, but where she has so much anxiety surrounding taking something that it kind of becomes self-reinforcing, that her anxiety gets worse. Of course, anything, whether inositol or Prozac or Buspar or whatever it is not going to work right away. So the idea is, how do you get her over the hump of the heightened anxiety and hypervigilance to get her to the point where she can start experiencing some benefit? And the two tools I would use for that is, one, starting at a dose so low that it's almost homeopathic. I might use liquid Prozac, for example, and have like 1 drop of liquid Prozac that's 1/10 of a milligram. It's more of like a behavioral habituation to it than it is like for efficacy, but then slowly going up from there. And even then in the inositol, I probably would start at like, I don't know, 0.5 gram or something, and have her do it an hour before she's going to meet with me so that we can kind of talk through it, have her do a breathing exercise through it if she's having any anxiety, and kind of counseling her of the process of a panic attack, like explaining how it's a feed-forward loop, explaining how focusing on the symptoms makes it more likely that it's going to get worse, and that wanting to encourage her to have some tolerance to the anxiety symptoms, but like having it on a 1 to 10 scale. I might explain it like, hey, so when you have a panic attack, you're at a 10 out of 10. I want you to be willing to feel a 6 out of 10 in terms of discomfort when we're starting something, but you let me know if it gets to be a 7 out of 10. So I kind of would want to start whatever dose of something gets her to maybe a 6 out of 10, because then she can habituate herself to that feeling of discomfort, get used to it, and then gradually go up from there. I think the inositol is great, saffron's great, that also has evidence. I probably, like you said, the limiting factor is not going to be waiting to see if it works. The limiting factor is just going to be waiting to make sure she tolerates it. I would buy the Treatments That Work series for, if you don't already have it, for panic disorder. It's Mastery of Your Anxiety and Panic. There's the therapist guide and the workbook. CBT for panic disorder is very straightforward. It's kind of similar to CBT for generalized anxiety disorder, and you just go through the book and you do certain exercises, and you have to teach patients how to rate their anxiety on a 1 to 10 or 1 to 100 scale. This is true for any anxiety related CBT, and it's also true if you're doing any kind of exposure therapy for PTSD. PTSD, ERP for OCD, CBT for panic disorder. It's called the SUD scale, Subjective Units of Distress Scale. I'm going to go into a little bit of detail because I think this is useful for people with a lot of different types of CBT. You want to get patients used to using the vocabulary of you can ask them, what's your SUDS? And they give you a 1 to 10 number. And the way I have patients start is to create anchors. I describe, hey, so like for example, with this patient, hey, so when you're having a panic attack, that's a 10. That's a 10 out of 10. What's the time in your life you felt the most calm and relaxed in your life? And I'll make them tell me a specific time. Oh, I was on vacation in Hawaii and the view of the ocean and this, and I'm like, okay, great. That's a 0 or a 1. Now let's come up with a 5. And I tell them a 5 is kind of somewhere in the middle where you're in a situation, you don't love it, but it's tolerable. So for a lot of people, that might be like being at the dentist, as long as you're not afraid of the dentist. So kind of if you're not afraid of the dentist, you can tolerate it, but you don't love it. That's like a 5. Or if you don't love crowds, but you're not afraid of them, like being in a crowded shopping mall, just kind of, I'd rather not be here forever, then that's a 5. So I have them anchor to like what a 5 is. And then I tell them, I want to put you in situations that are going to get you to a 6 to a 7, but not beyond. Because you want it to be a challenge enough that they're learning to tolerate something uncomfortable, but not so challenging that it's overwhelming. So like you might have them do the exercises of like breathing through the straw or spinning in the chair in a circle to mimic the dizziness, the breathing through the straws to mimic shortness of breath, running up and down stairs to mimic the tachycardia and also kind of shortness of breath to some extent. And then ask her through that, like, okay, what's your SUDS? What's your SUDS? Oh, it's a 6. Okay, great. What's a 7? Oh, it's an 8. Okay, then you maybe pull back a little bit. And you want to get them to stay at a 6 to a 7 for at least 20 minutes. 20 minutes is like the minimum, because what happens is, this is the cycle of anxiety over time. When you put someone in an anxiety-provoking situation, over the course of the first few minutes or so, the anxiety is going to peak. And then at some point, it's going to start going down. And this point where it starts going down is around 20 minutes. And you want the person to experience, they're not going to get back down to baseline, but you want them to at least experience what's happening here, which is their body self-regulating. You want to put them in a situation that makes them uncomfortable, let it peak, and keep them there without them engaging in the typical avoidance strategies they might do, which could be like mentally checking out. If it's OCD, it could be doing the compulsion. You want them to experience the feeling of the anxiety going down on its own. A magical thing happens when someone experiences that, of like, oh, this doesn't last forever. And then once someone experiences that, then you repeat it and you repeat it. I had like a supervisor who taught me all the exposure therapy I do. She taught me this. She was a big like OCD ERP person. And she would just say like, repeated and prolonged, prolonged and repeated. You keep like hammering at it, not letting them get above a 7. Again, you don't want to overwhelm them. You don't want to flood them. You want them to feel a sense of efficacy and success, like they're overcoming something, as opposed to feeling totally overwhelmed. So anyway, I know I kind of went on a tangent, but for a person like this who basically has no significant psychiatric history prior and very straightforward, kind of uncomplicated panic disorder, she's going to respond really well to that kind of therapy. Even just the psychoeducation about how panic disorder works, and it's described really well in that book as well.